Cardiac Surgery for Women, and the Director of Cardiothoracic Surgery, Dr. Juan Grau, will be speaking to us. Welcome, Dr. Grau, and thank you for joining us today.
Thank you very much. It's a pleasure to be here with you today, virtually. We have, Linda and I, when we're preparing this lecture, we thought of how to make it somewhat, not practical but informative, and not to bore people with just a lot of statistics. Although the statistics have to be mentioned because they are very important. So we divided the lecture in three parts. One part is giving examples of how women in particular get to my clinic. And I think women are a very particular substrate of patients that come normally late and very stoic in general because they have been caring for their families and their loved ones, and they have always put themselves last in the list. Then after that, we're going to talk about the research as it pertains to women cardiovascular disease. And finally, I will, move the presentation or hand the presentation over to Mary Collins, who will talk to you about the fantastic and outstanding cardiac screening program that we have for both, for men and women, but particularly she's going to be addressing women in this particular lecture. So these are the goals for today. I hope we accomplish them all, and they are clean, succinct, and constructive to people. The first thing we're going to do is to go over the cases. I think the cases are very illustrative because these are real cases. These are not, things that happened in the abstract. These are day-to-day women that I've been caring for in the past years since I've been here, and also while I was, professor of surgery and director of the fellowship program at the University of Ottawa Heart Institute in Canada. This is a lady that I met when I came here to Valley. She is a 59-year-old woman, very active. She's a mother. She has become also a grandmother. She works full-time, and she's very active in the community. She has been healthy throughout her life, but she claimed that she was not having that much energy. And that was basically the symptom. It was a vague symptom. It was not very specific. But she clearly could not do the aerobics classes that she was able to do in the past. She was struggling. She had to stop. She was feeling some heaviness on her chest, although it didn't have the typical left arm pain some people describe, or jaw pain. She will also complain about sometimes the heart racing. When the heart races, it means that it's in trouble. The heart should not be racing. It's not a machine that races as a sport. It's a machine that is supposed to perform depending on the demands of oxygen that the body has. And so your heart should only be racing when you are demanding a lot of oxygen, and that is when you're exercising at peak exercise. Otherwise, it's really an abnormal symptom. She doesn't want to complain. She didn't want to complain. She didn't want to create any fuss. She didn't want to bother anybody. So she went to the primary health physician in the Valley community, Valley Hospital community, and she was giving advice as maybe some weight will be important for you to lose, which is actually important advice to be given. It wasn't clear this chest heaviness, whether it could represent some GI symptoms such as heartburn. And anxiety could be responsible for your heart racing, which is true, but is not. It shouldn't be an immediate association that your heart is racing because you are anxious. I mean, you have to rule out all cardiovascular causes of your heart racing and you feeling unwell before you claim anxiety as the cause of it. The typical symptoms that we find in very typical patients, such as jaw pain, neck pain, precordial pressure, were not present in this patient. The symptoms were not very serious, so she was not treated emergently and urgently. There was no reason either, anyway, to do that, but she went through the regular diagnostic testing you would undergo if you have these complaints, which is a treadmill test, which is what we call a stress test, and that was not a clear cut result for her. That was that was a very good thing because you're having a negative stress test. It's okay if your symptoms disappear or the symptoms were caused by something else, but you're having a negative stress test and your system persisting means that you have to look further. And that's what was done. An angiogram eventually was the last test that she underwent. And there we found, the cardiologist found severe coronary blockages that were impeding the distribution of oxygen throughout the myocardial mass. Now, this is important because, as you're going to show you in a moment, the angiogram, the blockages were multiple. You'll see that in the piping system. But it's not uncommon in stress tests to be a negative stress test when multiple, blockages are present at multiple levels. The reason for that is any stress test, whether it's a nuclear stress test or an exercise stress test, bases the results or its results on the differential perfusion of different areas of the heart. For that, you ideally want to have one area that is very, very narrow in terms of blood flow, is just really limited, and other areas that are less limited. So that contrast of grays, if you will, gives you the positivity of that stress test. So I have seen, unfortunately, many stress tests being negative. And what I tell the patients is that if your symptoms persist, we are moving directly into a CT angio or a regular angiogram. In this case, the patient went for a regular angiography. This is the angiogram. This probably doesn't mean much to a lot of people that are listening to this lecture, but this is a piping system. And if you can see, if you see the beginning of the piping system here when I have my cursor, that's the way it's supposed to look everywhere, right? Very smooth, very open, very wide. All these areas here are areas of narrowing. So those are areas where the velocity of the blood flow is going to be significantly increased because it has to go through the area of narrowing to feed the heart muscle. Linda was very kind to put all these arrows for the audience so you can see these are areas that are very, very abnormal, the areas of significant narrowing of blood flow through different areas, through different walls we call of the heart. This is a ramus intermedius, is that we call this artery. This is the left anterior descending artery. This is obtuse marginal artery. And this is what the lady had a lot. Anita had a lot of disease distributed throughout the coronary tree. Now, this is not uncommon, and it's not uncommon specifically in diabetics. And unfortunately, in women that are past the age of 50, 55, when menopause has already set in, and women start developing the same, disease that men had developed in decades before, and they do so in a much rapid, pace, and with a significant progression to compare with when you compare them to men. This is the operation that was done for Anita. This is the left internal mammary artery that comes out of basically your neck. We connect this artery to another artery, which is the right internal mammary artery that is behind the other side of the breastbone. These arteries normally run behind the breastbone. We mobilize them, and we use them as new paths of blood flow to feed the heart. You can see that I connected those two arteries, and basically what I generated here is a neocoronary artery tree that now brings the blood flow preferentially through the heart to the heart muscle through this anastomosis that you can see here. This is connected there, this is connected there, this is connected there, and that gives now blood flow to the entire myocardial to the myocardial mass. Now, what is relevant about this particular operation is that what we call a total arterial revascularization, meaning the patient has arteries that, if you see, they look very healthy, right? They look very healthy now, and they will look very healthy in 30 years from now. We have now NIH funding to try to explain why that is. We know that in the same patient, in this case Anita, you have the coronary vessels being quite diseased, and then the vessels that we used to use to do the bypasses, which in this case are the arteries behind the breastbone, or the artery that feeds the your arms from we call them the radial arteries, are immune to the development of what we call atherosclerosis. So not only you're bringing new blood flow to the heart using these conduits, but you're also doing that with a conduit that is not going to develop the disease that brought the patient to the operating room in the first place, because they are resistant to atherosclerosis. In addition, this operation was done with the two conduits being connected without going in the heart and lung machine and without touching the aorta of this patient, so the risk of stroke is very, very low, and that's what concerns the patients mostly. This is the standstill image of what I just described to you, the three bypasses done to different areas of the heart. Basically and technically, what this means is that the heart now gets blood flow through a complete new coronary system that you have created artificially, bringing the flow through this artery called the left internal mammary artery. The longevity of this operation is the longest in the history of medicine. This operation will last for 25 to 30 years in terms of patency. And actually, some people are starting to publish now 35 years. This is the side-to-side comparison of the areas that were narrowed, as you saw before, to now the new coronary system bringing new blood flow to the areas that are narrow. If you can see this side to side now, you can see how preferential flow is generated and created through this piping system, fitting the whole heart muscle versus the old coronary system, which eventually will eventually occlude these areas of narrowing, and this will be the preferential highway of flow of blood towards the heart. Now we're going to talk about Theresa. Theresa is a 35-year-old woman, much younger than Anita in terms of, and she's a very different time in her life. She does have very young children, 3 of them, and she's a software engineer that works as a part-time, works part-time, especially after COVID. She had no problems. She claimed 3 normal pregnancies. She has no health concerns. But she said that she feels tired every time she tries to do something what she calls out of the ordinary. I didn't know what out of the ordinary meant until I realized the out of the ordinary means running after her children in the park when they're trying to be rambunctious. She's very busy with her family and with her obligations, and she has been not tending this or taking care of this for a long time. As I mentioned, when she plays with her kids, she feels short of breath. She can definitely do things that other mothers can do in the park. The family doctor was not very worried. She said, "Well, you're busy, and maybe that's part of being, the mother of 3." One day, she was taking her 4-year-old daughter up the stairs, and she had what we call a syncopal episode, which means you really technically pass out. It means that something is not providing the adequate blood flow this time to the brain, and this normally is either caused by problems in your neck directly, which at 35 are very unlikely to be the cause of problems in terms of the piping system going to your brain, or your heart is in trouble, and you need to pay attention to that, because that could be the source of the lack of blood flow to your brain. So again, was referred to a cardiologist, and the cardiologist sees that something is of the matter, but it's very unclear as what the problem is. And here at the Valley Hospital, we have generated a very sophisticated testing system, unit for specifically these particular cases. If a 35-year-old woman, she cannot play with her children in the park, that is remarkably abnormal. And it is our job as diagnosticians and eventually surgeons or cardiologists to figure out what can we do to help her. The very first step, as you can imagine, is to figure out what is wrong with the lady before we give her a solution. To do that, I'm going to just very briefly summarize the valves that we have in our hearts. The valves are separated into the heart. Basically, you have to think of it as of your Christmas tree lighting, meaning whatever happens in these chambers, the right-sided chambers, has to happen on the left-sided chambers. This is what we call a circuit in series. So if your Christmas light bulb, one of the bulbs goes off and it dies, you will have probably the sad experience of having to return the whole thing or put it in the garbage, because then the whole system doesn't work, just because that electric system is in series. So here's exactly the same thing. If something happens to the right-sided chambers, same thing is going to happen to the left-sided chambers. So if this part gets sick, eventually will affect this part. If this part gets sick, eventually it's going to affect this part. You have two valves on the right side of the heart and two valves on the left side of the heart. These valves called right here that separate the upper chamber from the lower chamber are called atrioventricular valves. And they are basically what we call inlets of blood coming either from the venous system that becomes without any oxygen, or the one that comes from the lungs already oxygenated into the left ventricle and to be ejected through the rest of the circulation. The tricuspid valve is the first inlet that the blood sees upon arrival after passing through the liver and becoming detoxified by the liver. It crosses the tricuspid valve, goes to the pulmonic valve, and it goes to the lungs to be oxygenated. Once this valve is called pulmonic valve, is the outlet valve of the right-sided chambers of the heart, meaning the right ventricle. When the blood comes back to the left atrium, comes already oxygenated, it's going to go through the inlet called the mitral valve. And once is ready to be ejected by the ventricle, is going to be ejected through the aortic valve, which is the outlet valve of the left-sided chambers, to the rest of the circulation. Theresa's problem was that she was built a little bit wrong, if you will, and this mitral valve was causing trouble and interacting with another part of her heart that causing an obstruction of the ejection of blood from the ventricle. And that's why she passed out, carrying her 4-year-old kid up the stairs, is because at that particular moment, the perfect circumstances took place for this obstruction to be present. This is a normal mitral valve in the heart. It looks, this is the valve of this particular patient. It looks normal, but actually, when you look at this view, you see this thing. It's called the anterior leaf of the mitral valve. This is called the posterior leaf of the mitral valve. They should meet in the back, and they should be meeting exactly the same level. If you pay attention to where my hand here, where my cursor is, the anterior leaf of the mitral valve bends over as an L, if you will, in an abnormal manner, meaning that this could potentially obstruct the flow of blood through this passage called the left ventricular outflow tract towards the aortic valve. Now, this is better demonstrated with this graphic that Linda did for me. This is the mitral valve opening. The blood is supposed to arrive to the ventricle, and unobstructed is supposed to be ejected through the aortic valve, as you can see here. Now, when you are at rest and your heart has a very low heart rate, with your heartbeats are very low in number, then if you have this condition, then you may be all right. You may not have any trouble. When your heart, as you can see here, when your heart starts, so I'm going to show you here. This is Theresa. The gradients, meaning the pressure differences from the chamber of the heart that ejects the blood to above the valve, should be in between 5 to 10 millimeters of mercury, whether you're measuring the mean or the peak gradient. And you can see that Theresa had normal gradients, had a mean gradient of 3 and a max gradient of 6 millimeters of mercury. This is tragic, but it's actually reality. This lady complained of something. The testing that was done at rest was normal, and she was told that there was nothing wrong with her. Now, the problem is, as I said before, is that her symptoms persisted. And then we saw her in the clinic and realized this is her doing a stressed echocardiography, meaning when I when I raise the heart rate to 123 beats per minute, you can see here the number, then her heart behaves in a completely different way. This area is completely obstructed. This is high flow velocity underneath the aortic, the mitral valve, with torrential mitral regurgitation that was not present during resting conditions. So you can see that if you don't do this testing, you will not find what is wrong with the patient, and you will not be able to help the patient. This is the image of basically the tube. At the end, if you will, you can see that a cylinder, right? So the cylinder that should be open at the time of ejection should be looking like this. Now look at what happened when I put her under stress conditions. She basically has no opening, hence the syncopal episode that she experienced when she was carrying the kid upstairs. Now, the gradient went from, you saw before, 6 and 3 to 233 millimeters of mercury. This is a ridiculous number. This is a number that could cause sudden death immediately. And again, the tragedy is that she didn't have all the features of patients with this condition. But when you look, this is another test that we're doing here at the Valley Hospital. It's called CNS-CT. It's a unit that we opened recently. And you can tell, you see this bending here that occurs at this level? That bending in this scheme or this graphic that Linda made does two things. Number one, moves the coaptation in between these two leaflets towards this area and makes it perfect so this part of the mitral valve can obstruct the flow of blood towards the outside. This lady was operated on. We did an operation that is only done here at the Cleveland Clinic in Ohio. And this is the result of her heart after a year from, a few months from surgery, where you can see that the outflow tract of the ventricle, the flow of blood is now completely unobstructed. We have rearranged her ventricle, moving things back. We have resuspended the mitral valve in that direction. We have cut abnormal chordae. Anyway, technical things that we have to do to make this heart whole again. This lady now is training for a triathlon. This is going from not being able to watch her kids in the park. Now, is this a unique experience? Are Anita and Theresa unique members of the women community? No. Heart disease kills more women than any other condition in the United States, and actually not in the world, because in the world there are many other problems. But in the Western societies, this is constantly a reminder that ladies feel protected, and very rarely are. You can see the statistics here. Now, why is that? Well, it's because the way they present, the way they experience cardiovascular disease is completely different. It has to do with their physiology, with the hormonal protections when they are young, that is lost over time as they get into their 40s, 50s, and then 60s. And the rapid progression of atherosclerosis and other conditions, disproportionately so to the age of the patient that was somewhat healthy, let's say a decade before. So a lady that is 55 needs to start watching herself very closely as she grows into the 60s and 70s, because she's going to be, if she's at risk, she's going to be progressing much quicker than a man would otherwise. Then we see, and this is very unfortunate, when we see the outcomes of different procedures, and I looked at, mitral valve repair, one, coronary bypass, another, just for this lecture, the outcomes are also worse. And this is really, it's multifactorial. It's not just only one thing that causes this, but several, and we're going to discuss them in a moment. You can see the cases that I just showed you. You can remember them, and then read what we just wrote in this slide, and it's all true. The way you ladies experience coronary artery disease is very different from the way men experience them. As I mentioned, you are much more stoic, and you tend to attribute those symptoms to something else, whether it's reflux, whether you're having a bad day. They are normally delayed in terms of receiving care compared to men, and they present with much more advanced disease than men when they are arriving to my operating room or any other cardiovascular center. In general, especially former generations, they are much smaller in terms of the height and weight. So the arteries in your heart are smaller. The coronary artery size is directly related to your height. So women in general are smaller than men, and so that makes them more complicated at the time of surgical intervention to be able to do all the bypasses you need to do them safely. There are also particular anatomic things that we need to consider, such as large breasts, and that will affect the way patients heal, either a midline approach or a thoracotomy approach. This was a paper that was published recently in the Journal of Cardiovascular and Thoracic Surgery by my colleague, Dr. Jabaji, looking at women that undergo cardiac coronary artery revascularization called CABG. He published very elegantly that they are much sicker when they come to the operating room, and they come with much more advanced disease than men. Sometimes that limits the surgical options for them in terms of getting an optimal result. In addition, if you already come with a much lower function of your heart because this has been progressing blindly in a way, then that may improve or may not improve after surgical intervention. Mitral valve disease is another condition. This is what, if you remember my second case, they tend to be referred much later. They tend to come. I cannot tell you. I remember this year alone 3 patients that came in extremis with a valve completely detached from the ventricle. I was able to fix them, but this is unnecessary. When patients are known to have a murmur, and you're a lady, that needs to be followed very, very closely because they will need to intervene when you are healthy, because your outcome is going to be just much better than if you come to us when you are very advanced in terms of your condition and your overall health. Unfortunately, many surgeons tend to replace valves in ladies that have not that much tissue available for repair, and this shouldn't be. This is just the surgeon's fault. I mean, there are many techniques that we are applying these days that allow you to use tissue in a wiser way and in a much more efficient manner, and provide repair to all the patients, all the women that have had surgery here this year for mitral valve disease and congenital conditions. All of them have been repaired. No one replacement has been done. Leipzig is the biggest hospital in Germany. That they do about 6,000 hearts a year. It's a very large center. When they compare their data, they realize that women have worse outcomes, but only when women were taken as a group. When then you pair women and men based on the risks, the relative risk that they presented with to the hospital, then they had equal outcomes. Meaning, but when you present at the same time men present, then you have a much better chance of doing well. Whereas if you present much later, obviously you will never match the outcomes that we can achieve in men. So the system has a bias. You need to know the system is biased towards women in the wrong way. And it is our job to make sure that ceases to exist and we are able to screen for women's cardiovascular disease very early on. We are learning very much about this. I think this is now, we are all very conscious about it. My team here at the Valley Hospital, and especially the preventive cardiovascular surgery team that we have, that is actually led by women, all of them, and nurse practitioners that know exactly how to look for these conditions and how to screen for these conditions. You should take advantage of it because, and again, not only you as women, but also your partners, whether they're women or men, they should also, take this advantage. There's nothing like for me to go to the operating room with what I call an elective operation. It changes everything about the outcome of those patients. So I hope this was helpful. If there are any questions, I'll be more than happy to answer them.
Oh, Dr. Grau, this was just amazing, and just the visuals were really powerful. Just explained it so well. We don't have any questions at the moment. I think it's been so thorough and comprehensive. Is Mary Collins going to hop on with us for a few minutes?
Yes, I am going to unshare my screen if I can.
Okay, sure.
Yes, I am here and ready to go. We're just getting our screen up.
Oh, great.
Yeah.
You have to unshare first.
Yeah, I need to unshare, but I need someone to help me unshare this. Why is this not opening like a normal thing?
Share right
No, the whole thing disappears. Oh, here it is. That's it. You got it.
Okay. Okay, Mary, you're welcome to share if you have one. Oh, good. Good. There you go.
Okay, we're starting. Okay, so you can see my screen?
Yes.
Oh, that's great. All
Great.
right, because I can't, but all right, let's go. So, and you're going to help me here. So, thank you, everybody, for giving us this time. Certainly, thank you so much, Dr. Grau. That was just so impressive. And as Dr. Grau has communicated to the group, several of the very important things, or one of the most important things that he did say is, ladies, please realize that cardiovascular disease is your #1 issue. You know, we are getting more and more aware of this. However, when we do little polls and check in on the knowledge and awareness of women, very often women are identifying breast cancer as their major health issue. It is not. It is heart disease, and it trumps all forms of cancer. So important that Dr. Grau pointed that out to you today. Keep that in mind. And that is one of the reasons that we have developed here at Valley Hospital a program to help the women and men identify their risk for developing heart disease and becoming very knowledgeable and becoming their best advocates. So our cardiovascular screening program here is comprised of 3 different areas. #1, we do individual, very in-depth cardiovascular risk assessments on the individual. We also do a lot of community outreach. Susan is very familiar with this. We're asked very often to go out to speak to Rotaries, to different companies, to women's groups, to schools, to raise awareness and teach about this issue. And then we also provide cardiac support groups. And we're going to go through each of these coming up. So what is the screening comprised of? Well, first of all, the screening is conducted by a board-certified nurse practitioner who has extensive education and training in cardiovascular diseases. We start off with introducing ourselves, of course, and then going through a person's current symptoms. We do this for a couple of reasons. As Dr. Grau pointed out, symptoms present differently in men than in women. And they very often are much more subtle in women. It is not the thing that you see on television, the Hollywood heart attack, they call it, when a man is clasping at his chest and really looking like tremendous distress. That's pretty easy to point out that a person is maybe having issues and having a heart attack. However, with women, very often those symptoms are more subtle. Often it involves gastrointestinal symptoms like nausea, discomfort in the chest, shortness of breath is a very common symptom that women present with. So things that are a little bit more simple. Or subtle, excuse me. So we not only inquire about all of those types of symptoms, we also teach you at the time what to be looking for. Then we go through the risk factors. Yes, of course, we ask about your blood pressure. Do you smoke? Have you had any cardiovascular disease in the past? Those things that we kind of put in the bucket of traditional risk factors that you probably all are very aware of. But we go beyond that because we look at gender-specific things that can happen that will increase your risk of developing cardiovascular disease. For instance, did you know that your OB history is very significant in terms of your cardiovascular risk? So if you developed hypertension with your pregnancies or preeclampsia, that extreme, or diabetes during pregnancies, that you actually, it doesn't mean 100% you're going to develop these in later life, but we now know that it does increase your risk. We used to think the baby is out, you're okay. That's not what we realize anymore. So this group of people, we really do inquire about and let them know that they need to be monitored throughout their life. And then there's also emerging and other risk factors that we're seeing does have an association with cardiovascular disease, such as some of the inflammatory diseases, rheumatoid arthritis. They do plague women in a little bit of a higher degree than men. And even we're looking at things that cause inflammation through the body, periodontitis, things like that, because when we do dissect some of that plaque that Dr. Grau referred to when he tries to bypass the arteries, in the heart, we are finding that it is made up of more than just cholesterol. It is also made up of inflammatory molecules. So important for us to know. Yes, we talk about your family history. There are certain ages, a woman that has cardiovascular disease before age 55, or a man that has it before age 45. We feel that does we have to investigate that with you. Could there be a familiar tendency for you to develop cardiovascular disease? So we do inquire about that. Your social history, smoking, all of that. We went over alcohol consumption. Alcohol in too much doses or each day can actually damage the heart muscle itself. We will inquire about the medications that you're taking. We'll go over all the vitamins and supplements. Many times this prompts lots and lots of questions. We stick to what the research shows us. There's lots of good advertisement about different compounds that can reduce your risk or help you. However, we will give you the research based on that. Then we ask about your quantification of physical activity, because we know that if you get at least 30 minutes a day, 5 times a week, that you can ameliorate the risk or decrease your risk of developing heart disease. We go over your eating habits. We do endorse those dietary approaches that have been shown by research to decrease the cardiovascular risk, overall risk. And we recommend things like the Mediterranean diet, and if you have hypertension, the DASH diet, which simply is the Mediterranean diet with a little bit less salt. So we go through all that. While we have you there, we go through other health screenings that age are appropriate that you should be doing. Mammograms, colonoscopies. We're nurse practitioners, so if you're out of date with that, we can write you a prescription and have you follow that up. And then we are here at Valley Hospital under Dr. Grau's direction. We have a very robust aortic aneurysm surveillance program. And we are, as research goes by and we learn more and more about this, we find that there can be such a familial tendency. So we do inquire specifically if you've had first degree relatives, particularly that have had any vascular endothelial disease or have had sudden death or had aneurysms in your past. So we really try to be very comprehensive in our inquiry about as much as we can understand from who you are so that we can set the risk. Then we go on to the physical exam. This is aimed at the vascular system, which does include obviously listening to your heart for any kind of valve or irregular, rhythm sounds, listening to your carotids, your arteries, in the belly, your abdominal aorta. Of course, we take your blood pressure, and we do it on the right arm and the left arm because that also can give us some information. And we suggest that people have that a couple times throughout their lifetime, at least at baseline. We will do what they call either biometrics or anthropometrics, which is your body mass index, fat percentage, waist circumference to hip ratio. All of that gives us a little bit more information about your whole overall cardiovascular health. Of course, we do look at lab work, and these are the things that we are interested in: your lipid profile, that's your LDL, HDL, triglycerides, your high sensitivity C-reactive protein, and the HSCRP. And remember, I talked about the inflammatory markers that we find in plaque. So this is a blood test that's able to give us a little bit information about the inflammatory status. We do hemoglobin A1C to take a look at where you might be on the spectrum of developing diabetes, pre-diabetic, all of that. It gives us more information than just a single glucose measurement, and to help you understand what you are. Diabetes certainly is a risk factor, increases your risk for developing cardiovascular disease. And then the one supplement that we are interested in, is vitamin D. So we do recommend that you have a baseline vitamin D has been associated with a decreased amount of cardiovascular disease and some forms of cancer. So there is some good research on this. This is the only supplement that we are interested in and would recommend that people make sure that their vitamin D levels are appropriate. We live in the north here, so a lot of time, you know, many months of the year, we're not getting a lot of sunshine. Then when we do have the sunshine, we're putting on the you know, UVA and UVB screening, which is helpful from the sun to help us make vitamin D. So this is why often we are finding ourselves that we have low vitamin D levels. So we do look at that. And then what do we do? Well, here's one of our wonderful nurse practitioners, Lily in Toronto. She's fantastic. Everyone loves her. And we will give you a lot of information after that. First of all, we will give you the results of any lab works and biometrics that we've taken. We will tell you where we feel you should be, where your goals are, and then we will give you recommendations. And those recommendations always will include therapeutic lifestyle. We give you a whole folder of information on the Mediterranean diet, the DASH diet, how to, you know, get exercise throughout your day, 30 minutes, 5 times a week. You can divide that into 10-minute intervals, 3 times a day. Research does tell us it gives you just as much goodness as 30 minutes at a time. And then if you are going to be, there's a call on here. Okay, I'm sorry that my screen's just getting interrupted. But anyway, and then because, you know, being nurse practitioners, certainly if there's anything that we find that we're of concern about, we can make a referral to one of the cardiologists to you know, for an echo for further study and, you know, really try to take care of you. But or to other programs that we have here at the hospital, such as sleep apnea programs, our nutritionists, all of that. People really have given us a lot of good feedback about the educational programs that we do give them and the educational materials and plan. So that's what we do with, you know, so this is basically what we look at, the education, the evidence-based eating plans, the physical, the stress reduction, how important is that? And certainly then any referrals. Okay, and then so that kind of is what we do for the individual. You make an appointment and that's your time with your nurse practitioner. And it's probably 45 minutes, sometimes an hour, sometimes we can get real long-winded and we go over an hour, but it's a very good review. We get great feedback. So then the other part of our program is for community outreach, right? Because we want to cast the widest net that we can. So we will go out on the road and go to different companies, the workplaces that people are, social gatherings we've done screenings at, and usually they're quite, you know, fun, festive. We try to make it, you know, very helpful and interesting for the each individual that comes. But we have done mega screenings when we've put all hands on deck with nurse practitioners and administrative assistants that help us. And we've gone through in a day 80 to 100 screenings so that we can cast as wide net as we can. We talk to your OBGYNs because if anybody, well, many of you on the call, probably the only doctor you go to is your OBGYN. So we interact with them a lot. Certainly because we want them to send us those patients that have had any kind of issues during their obstetrical course of hypertension or diabetes. And we also like to give them a place to send their patients that have issues that are related to heart disease that are a little bit hesitant to maybe make an appointment with a cardiologist. But then if you need a cardiologist, we get you there, that's for sure. You may have noticed if you live in the community of Ridgewood on a pretty yearly basis, we participate in the American Association Heart Walk, and we always go out there with a table. We've actually done screenings at these heart walks, and it's really a good place for us to reach, you know, a lot of people. So that's our community outreach portion. And then we have a support group for those patients that are diagnosed with cardiovascular disease. And these support groups, they're in the evening once a month. And they're 2 hours. And the first hour is usually an educational selection of their choice. They tell us the types of things that they'd like to learn about, and we will get them certain specialist speakers. And then the second part is the group kind of getting together and truly becoming a support group where they can share stories and develop friends. And as they go through this journey, we always try to give them some fun things to do. We've taken them for cooking classes in Ridgewoods and grocery shopping trips to learn how to shop the perimeter of the grocery store as opposed to the interior. So if I'm going to leave you with anything, what I want to tell each woman here is please get screened. You need to be your advocate. This is your number one health issue. And by simply calling this number, 201-447-8125, you can, you will be assisted in making an appointment. So that's what I have to say to you today. And I thank you so much for being on the call and for your time. And I certainly will entertain any questions if you have them.
Oh, thank you so much, Mary. That was so comprehensive. It's a great reminder to us all, us women, that we need to take control of that. So